blot simulation 4. Same process, new questions. Read the command, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Read the command, most likely diagnosis, polyuria, polydipsia, high serum sodium and osmolality, dilute urine that stays dilute after water deprivation, but concentrates after desmopressin, central diabetes insipidus. Diabetes insipidus is a defect in water conservation. The water deprivation test does not concentrate the urine in either form of DI. The kidney keeps wasting free water. The desmopressin step is what separates them. Desmopressin is synthetic ADH. In central DI, the problem is a deficiency of ADH production from the posterior pituitary, so giving exogenous ADH works, and urine osmolality jumps, here from 90 to 480. The kidney responds normally once hormone is supplied. In nephrogenic DI, choice C, the kidney cannot respond to ADH receptor defect. Lithium, hypercalcemia, so desmopressin produces little or no rise in urine osmolality. Primary polydipsia would have a low serum sodium from water overload and would concentrate with water deprivation. The robust desmopressin response defines central DI. Read the command, mechanism of organ damage, bronze skin, diabetes, hepatomegaly, very high ferritin and transferrin saturation, HFE, C2A2Y mutation, iron on biopsy, hereditary hemochromatosis. Hereditary hemochromatosis is most often caused by mutations in the HFE gene, classically C282Y. The defect leads to inappropriately low hepcidin, the hormone that normally restrains iron absorption. With low hepcidin, the gut absorbs too much iron. Iron accumulates in the liver, pancreas, heart, skin, joints, and pituitary. Excess free iron catalyzes the Fenton reaction, generating reactive oxygen species that damage cells. This produces the classic triad of cirrhosis, diabetes, bronze diabetes from pancreatic and skin deposition, and cardiomyopathy. Choice A, copper accumulation, is Wilson disease. A different metal presents with neuropsychiatric symptoms in Kaiser-Fleischer rings. Choice C is alpha-1 antitrypsin deficiency. The HFE mutation with iron-loaded biopsy is specific for hemochromatosis. Treat with phlebotomy. Read the command, which enzyme is deficient, self-mutilation, intellectual disability, chorioathetosis, hyperuricemia, X-linked, Lesch-Nyhan syndrome. Lesch-Nyhan syndrome is a deficiency of HGPRT, hypoxanthine guanine phosphoribosyltransferase transferase. HGPRT is the key enzyme of the purine SA-alveolage pathway. It recycles hypoxanthine and guanine back into nucleotides. Without it, purine bases cannot be salvaged and are instead degraded to uric acid by xanthine oxidase, and de novo purine synthesis is upregulated. Both drive hyperuricemia. The result is the classic tetrad: intellectual disability, self-mutilation, chorioathetosis, and hyperuricemia with gout and urate stones. Choice A, adenosine deaminase, is SCID. Choice C, xanthine oxidase, is the enzyme ion inhibit by allopurinol. Its deficiency would lower uric acid, the opposite. Remember the mnemonic, HGPRT, he's got purine recovery trouble. Treat the hyperuricemia with allopurinol. Read the command. Which nerve was injured? Post-thyroidectomy, hoarseness with a fixed vocal cord, recurrent laryngeal nerve injury. The recurrent laryngeal nerve a branch of the vagus, supplies all the intrinsic muscles of the larynx except one. It runs immediately adjacent to the thyroid gland and the inferior thyroid artery, making it highly vulnerable during thyroidectomy. Unilateral injury paralyzes the vocal cord on that side, leaving it fixed and producing hoarseness and a weak, breathy voice. Bilateral injury is an airway emergency. Both cords can obstruct the glottis. Choice A. The external branch of the superior laryngeal nerve innervates the cricothyroid and is injured near the superior thyroid artery. Its damage causes voice fatigue and loss of high pitch, not a fixed cord. The fixed paramedian cord with hoarseness is the recurrent laryngeal nerve. Read the command mechanism of hypercalcemia. Young woman, bilateral hilar adenopathy, erythema nodosum, uveitis, elevated ACE, non-caseating granulomas, sarcoidosis. In sarcoidosis, the granulomas are made of activated macrophages and epithelioid cells. These activated macrophages express 1-alpha hydroxylase, the same enzyme normally found in the kidney that converts 25-hydroxyvitamin D to the active 1025-dihydroxyvitamin D calcitriol. In sarcoidosis, this conversion happens autonomously in the granulomas, outside normal PTH regulation. Excess calcitriol increases intestinal calcium absorption, causing hypercalcemia and hypercalciuria. PTH is suppressed by feedback. Choice A, PTHRP, is hypercalcemia of malignancy, not sarcoidosis. Choice D, primary hyperparathyroidism, would show Hg PTH each. But in sarcoidosis, PTH is low. The unregulated macrophage 1-alpha hydroxylase is a specific mechanism. Sarcoidosis also classically shows non-caseating granulomas, distinguishing it from the caseating granulomas of tuberculosis. Read the command, what inulin clearance represents and its value. Inulin is freely filtered, not reabsorbed or secreted, the gold standard for GFR. Inulin clearance equals the glomerular filtration rate because inulin is freely filtered at the glomerulus and neither reabsorbed nor secreted by the tubules, so the amount appearing in urine exactly equals the amount filtered. The clearance formula is urine concentration times urine flow divided by plasma concentration. That is 100 times 1 divided by 1, which equals 100 milliliters per minute, so GFR is 100. PAH clearance, given at 600, estimates renal plasma flow because PAH is both filtered and almost completely secreted, so it is nearly entirely cleared from the plasma that flows through the kidney. The filtration fraction is GFR over RPF, 100 over 600, about 17%. Distinguish these markers. Inulin and creatinine estimate GFR, PAH estimates renal plasma flow. Read the command, mechanism, and antidote. Farm worker spraying crops with the full cholinergic toxidrome. Organophosphate poisoning. Organophosphates in pesticides irreversibly inhibit acetylcholinesterase. Acetylcholine accumulates at every cholinergic synapse, producing both muscarinic and nicotinic overstimulation. The muscarinic effects are the dumbbells or sludgy picture, salivation, lacrimation, urination, defecation, GI cramping, emesis, plasmiosis, bronchospasm, and bradycardia. The nicotinic effects include muscle fasciculations and bradycardia. The nicotinic effects include muscle fasciculations and weakness. The antidote is tupron, atropine to block the muscarinic receptors, and pralidoxime to regenerate acetylcholinesterase before it ages and becomes permanently inactivated. Atropine treats the muscarinic symptoms but does nothing for the nicotinic fasciculations. That is why pralidoxime, which reactivates the enzyme, must be added and given early before aging occurs. Choices that block cholinergic receptors or given anticholinergic receptors or mismatch this poisoning. Read the command. Which molecular abnormality drives this? Massive splenomegaly, high WBC with full myeloid maturation, basophilia, low LAP score to 9, 2020, chronic myeloid leukemia. Chronic myeloid leukemia is driven by the 2922 translocation, the Philadelphia chromosome. It fuses the BCR gene on chromosome 22 to the ABL gene on chromosome 9, creating a BCR-ABL fusion protein. This fusion is a constitutively active tyrosine kinase. It is always on, driving uncontrolled proliferation of the myeloid lineage independent of normal growth signals. The result is a high white count with the full spectrum of maturation, basophilia, and splenomegaly. The low leukocyte alkaline phosphatase score distinguishes CML from a benign leukemoid reaction, which has a HIE-H score. This is why CML is treated with imatinib, a tyrosine kinase inhibitor that directly targets BCR. ABL is specific to CML, one of the great triumphs of targeted therapy. Choice A, PML-RARA, is APL. Choice C, JK2, is polycythemia vera and other myeloproliferative neoplasms. The T922BCR, ABL, is specific to CML. Read the command, organism, and first-line treatment. Recent antibiotic clindamycin, hospitalized, watery diarrhea, pseudomembranes, toxins A and B, Clostridioides difficile colitis. Clostridioides difficile is the classic cause of antibiotic-associated pseudomembranous colitis. Antibiotics, clindamycin is the classic culprit, but fluoroquinolones and cephalosporins are also common. Wipe out the protective gut flora, allowing C. difficile to overgrow. It produces toxin AN, enterotoxin, and toxin BA, cytotoxin, which disrupt the cytoskeleton of colonocytes, causing inflammation and the raised yellow-white pseudomembranes seen on colonoscopy. First-line treatment is oral vancomycin or fidaxomicin. Note, oral vancomycin works here because it stays in the gut lumen. The key shift to remember, metronidazole was the old first line, but current guidelines favor oral vancomycin or fidaxomicin. Also, stop the offending antibiotic and use contact precautions. Alcohol gel does not kill the spores, so wash hands with soap and water. Read the command, effect on the curve, and the benefit. Exercising muscle with high CO2, high temperature, low pH, high 2003 BBG, all factors that shift the curve right. These 4 factors, increased CO2, increased temperature, decreased pH, and increased 2003 BPG, all shift the oxygen hemoglobin dissociation curve to the REJ-T. A rightward shift means decreased hemoglobin affinity for oxygen. This is exactly what active tissue needs. Hemoglobin lets go of oxygen more readily, unloading it where metabolic demand is highest. This is the Bohr effect. The acidic, CO2-rich, warm environment of working muscle promotes oxygen release. Memorize the mnemonic. A rightward shift is caused by things that signal active tissue needs oxygen, high CO2, acid, heat, 2003 BPG, and exercise. A leftward shift, increased affinity, holds on to oxygen, is caused by the opposite, plus fetal hemoglobin and carbon monoxide. Right releases, left loads. Read the command, which protein is deposited. Chronic rheumatoid arthritis, restrictive cardiomyopathy, proteinuria, Congo red with apple green birefringence, amyloidosis. Which type given chronic inflammation? The Congo red stain with apple green birefringence under polarized light is pathognomonic for amyloidosis, misfolded protein deposited in beta-pleated sheets. The Ke way here is the type. This patient has long-standing rheumatoid arthritis, a chronic inflammatory disease. Chronic inflammation produces serum amyloid A as an acute phase reactant, which is processed into AA-amyloid. So this is secondary, or AA, amyloidosis, driven by chronic inflammatory conditions like RA, inflammatory bowel disease, and chronic infections. Distinguish the types by clinical context. AL amyloid comes from immunoglobulin light chains in plasma cell disorders like multiple myeloma. AA amyloid comes from chronic inflammation, as here. Beta amyloid is Alzheimer's disease. Beta-2 microglobulin accumulates in long-term dialysis. The chronic RA history points specifically to AA. Read the command. Which nerve roots were injured? Shoulder dystocia, lateral traction, waiter's tip, posture, intact grasp. Duchenne palsy, upper trunk, C5, C6. Duchenne palsy is injury to the upper trunk of the brachial plexus, roots C5 and C6, caused by excessive lateral traction on the neck, shoulder dystocia in newborns, or a fall onto the shoulder in adults. The affected muscles include the deltoid and supraspinatus, loss of abduction, the infraspinatus, loss of external rotation, and the biceps, loss of flexion and supination. The arm therefore hangs adducted, internally rotated, and pronated, the waiter's tip position. The hand is spared, so the grasp reflex is intact. Contrast with Klumpke palsy, injury to the Lowell trunk, C8, T1, caused by upward traction on an abducted arm grabbing a branch during a fall. Klumpke affects the intrinsic hand muscles, producing a claw hand, and can include Horner syndrome from T1 sympathetic involvement. Waiter's tip with a normal hand is upper trunk. Read the command. Which bias explains the apparent benefit? Screening detects cancer earlier, survival from diagnosis looks longer, but age at death is unchanged. Lead time bias. Lead time bias occurs when a screening test detects a disease earlier in its course, so survival measured from the time of diagnosis appears longer, but only because the clock started earlier, not because the patient actually lives any longer. The key giveaway in this question is that the actual age at death is unchanged. Screening moved the diagnosis date back, inflating the apparent survival time without changing the true outcome. Distinguished from length time bias, choice D, where screening preferentially detects slow-growing, indolent tumors that would have done well anyway, making screening look better. Lead time is about the clock starting earlier, length time is about which tumors get caught. The unchanged age at death specifically signals lead time bias. Read the command, pattern of inheritance. Stroke-like episodes, seizures, lactic acidosis, ragged red fibers, affected mother and maternal relatives, variable severity, MELIS, a mitochondrial disorder. This is mitochondrial inheritance. 2 clues, nail it. First, the transmission pattern, only the mother and maternal relatives are affected, and the father is unaffected. Mitochondrial DNA is inherited exclusively from the egg, so an affected mother passes it to ALL her children, but an affected father passes it to none. Second, the variable severity reflects heteroplasmy. Cells carry a mix of normal and mutant mitochondria, and the proportion varies, so expression differs even within a family. Ragged red fibers and lactic acidosis reflect defective oxidative phosphorylation. The disease described is MELIS, mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. Key contrast: in mitochondrial inheritance, an affected father transmits to no one, which immediately separates it from autosomal and X-linked patterns. Heteroplasmy explains the variable expressivity. Read the command. Mechanism of glomerular injury. Young woman, malar rash, arthralgia, positive ANA and anti-dsDNA, low complement, wire loop lesions, full house immunofluorescence, lupus nephritis. Lupus nephritis is a type 3 hypersensitivity reaction. Circulating immune complexes, especially anti-double-stranded DNA bound to DNA, deposit in the glomeruli. There they activate the complement cascade, consuming C3 and C4, which is why serum complement is low W. Complement and recruited inflammatory cells damage the glomerular capillaries. When the deposits are subendothelial and abundant, they thicken the capillary wall into the classic wire loop appearance, seen in diffuse proliferative lupus nephritis, the most severe and common form. Immunofluorescence lights up with everything: IgG, IgG, IgAIM, IgA, C3, and C1q, the full house pattern. The low complement is the key physiologic clue separating immune complex disease from pauci-immune ANCA-vasculitis, choice E, which has normal complement and no deposits. Choice A, anti-GBM, is linear, not full house granular. The full house pattern with low complement and anti-dsDNA is specific for lupus nephritis. Read the command. Mechanism of right heart failure. Severe COPD, right-sided failure signs. Edema, JVD, hepatomegaly, RV hypertrophy, pulmonary hypertension, normal left heart, cor pulmonale. Cor pulmonale is right heart failure caused by a primary disease of the lungs, not by left heart disease. In COPD, two mechanisms raise pulmonary artery pressure. Chronic alveolar hypoxia triggers hypoxic pulmonary vasoconstriction, and destruction of the alveolar capillary bed reduces the pulmonary vascular cross-section. The right ventricle must pump against this elevated pulmonary pressure, a chronic pressure overload. It hypertrophies and eventually dilates and fails, backing up into the systemic veins, jugular venous distension, hepatomegaly, and peripheral edema. The crucial defining feature is that the left heart is normal. That is what makes this cor pulmonale rather than biventricular failure. If left ventricular dysfunction were the cause, choice A, that would be the most common cause of right heart failure overall, but here the left side is explicitly normal, pointing to the lungs. Read the command. Most specific finding for the diffuse type: Linitis plastica, leather bottle stomach, signet ring cells, Virchow node, Sister Mary Joseph nodule, diffuse type gastric adenocarcinoma. Gastric adenocarcinoma has two main types. The diffuse type is characterized by signet ring cells, cells filled with mucin that pushes the nucleus to the periphery, giving a signet ring appearance, that infiltrate the stomach wall diffusely rather than forming a discrete mass. This widespread infiltration thickens and stiffens the entire stomach, producing the classic Linitis plastica, or leather bottle, stomach. The diffuse type is less associated with H. pylori and more often linked to loss of E. cadherin, which explains the discohesive infiltrative growth. Choice A describes the intestinal type, which forms discrete glandular masses and is associated with chronic atrophic gastritis, H. pylori, and nitrosamines. The metastatic signs here are classic: Virchow node, left supraclavicular, and Sister Mary Joseph nodule, periumbilical. Signet ring Linitis plastica is specific to the diffuse type. Read the command. Feature distinguishing this from NMS, SSRI, plus tramadol, rapid onset of agitation, hyperreflexia, clonus, hyperthermia, serotonin syndrome. Serotonin syndrome results from excess serotonergic activity, here from combining an SSRI with tramadol, which also raises serotonin. The hallmark that distinguishes it from neuroleptic malignant syndrome is the neuromuscular picture, hyperreflexia, myoclonus, and clonus, especially in the lower extremities, plus a rapid onset within hours of the offending drug. The patient is hyperthermic, agitated, and diaphoretic with these hyperkinetic, hyperreflexic findings. Contrast with neuroleptic malignant syndrome caused by dopamine antagonists, antipsychotics. NMS has lead pipe rigidity with hyporeflexia, develops slowly over days to weeks, and shows bradykinesia rather than clonus. So the discriminator is hyperreflexia and clonus with rapid onset for serotonin syndrome versus rigidity and slow onset for NMS. Treat serotonin syndrome by stopping the agents, supportive care, and cyproheptadine. Read the command, identity of the atypical lymphocytes. Young adult, exudative pharyngitis, posterior cervical nodes, splenomegaly, amoxicillin rash, positive heterophile, atypical lymphocytes, EBV mononucleosis. Epstein-Barr virus infects B lymphocytes by binding CD21, but the atypical lymphocytes, the large reactive Downey cells seen on the smear, are not the infected B cells. They are reactive CD8 plus cytotoxic T cells responding to and attacking the EBV infected B cells. This is a key, frequently tested distinction. The virus is in the B cells, but the dramatic lymphocytosis is from the T cell immune response. The splenomegaly is from this lymphoid proliferation, which is why contact sports are restricted to avoid splenic rupture. The amoxicillin or ampicillin rash is a classic clue. Giving these antibiotics in EBV monocauses a near-universal morbilliform rash. The positive heterophile monospot confirms the diagnosis. EBV is also linked to Burkitt lymphoma, nasopharyngeal carcinoma, and Hodgkin lymphoma. Read the command, which embryologic structures failed. Neonatal hypocalcemia with tetany, conotruncal heart defect, absent thymus, recurrent infections, Dye-George syndrome, 22q11 deletion. Dye-George syndrome results from a microdeletion at chromosome 22q11.2, causing failure of development of the third and fourth pharyngeal pouches. These pouches give rise to the thymus and the parathyroid glands. Failure produces the classic triad. Remember catch-22, cardiac defects, conotruncal, like tetralogy of Fallot and truncus arteriosus, abnormal facies, thymic aplasia, causing T-cell deficiency and recurrent viral and fungal infections, cleft palate, and hypocalcemia from absent parathyroids, causing tetany and seizures. The T-cell deficiency from thymic aplasia explains the susceptibility to viral and fungal infections, while the absent parathyroids explain the hypocalcemia and tetany. The conotruncal cardiac defects come from associated neural crest involvement. CATH22 ties it together. Blob 4 is done. Let's review the 5 biggest traps from this blob. Trap 1. Central versus nephrogenic diabetes insipidus. Neither concentrates urine with water deprivation. The desmopressin step is the discriminator. Central DI responds because the kidney works, nephrogenic does not because the kidney cannot hear the hormone. Trap 2. Hypercalcemia in sarcoidosis comes from granuloma macrophages making active vitamin D with PTH suppressed. Do not confuse it with primary hyperparathyroidism where PTH is high. Trap 3. Amyloid subtype. Congo red with apple green birefringence confirms amyloid, but the clinical history tells you which protein. Chronic rheumatoid arthritis points to AA. A plasma cell disorder points to AL. Trap 4. Mitochondrial inheritance. The unaffected father and affected maternal line is the giveaway. An affected father transmits to no one. Heteroplasmy explains why severity varies within the family. Trap 5. Serotonin syndrome versus neuroleptic malignant syndrome. Serotonin syndrome is hyperreflexia in clonus with rapid onset. NMS is rigidity with hyperreflexia developing over days. The neuromuscular exam separates them. Train process, not memorization. 4 blocks down, your pattern recognition is getting faster every set. StepLogic, learn how to think, not memorize.